This is Professor Ariel Ortiz Lagardere, broadcasting from the International Bariatric Club studios in San Diego, California. The theme of today's IBC Oxford University Hot Topics in Surgery exclusive event is Marginal Ulceration after Laparoscopic Roux-en-Y Gastric Bypass and Mini-Gastric Bypass, Medical, Endoscopic, and Surgical Management and Surveillance Strategies. And will feature experts from Mexico, Russia, Italy, Israel, India, Brazil, Australia, Germany, the United States, the United Kingdom, and the United Arab Emirates. We would like to thank our partners Zoom Video Communications, YouTube, Facebook, Bariatric News, and Cinemed for setting up, promoting, and accrediting this webinar, which is sponsored by our platinum sponsors, ConMed, Medtronic, Ethicon Endosurgery, CMR Surgical, Lexington Medical, Panther Healthcare. Our gold sponsors, WL Gore, Reach Surgical, Karl Storz, Bariatric Solutions, Baxter, Advanced Medical Solutions Liquid Band Fixate, Feng Medical. Our silver sponsors, Mass Bariatric Technologies, Richard Wolf. This 30th IBC Oxford University webinar is streaming to millions of viewers from over 200 countries and territories through the IBC website, ibcclub.org, the IBC YouTube channel, via Facebook Live to the IBC Facebook page, the IBC Twitter feed, LinkedIn, and via IBC Instagram. This event is organized by Mr. Harris Khwaja, Consultant Bariatric Surgeon and Director of IBC Global Education, based at Chelsea and Westminster Hospital Imperial College London and Christchurch, Oxford University. This event will be chaired by Professor Rafael Alvarez Cordero from Mexico and will be moderated by Dr. Alexander Neymark from Russia and Professor Mario Musella from Italy. We also have with us Dr. Robert Rutledge from the United States. He is inventor of the mini-gastric bypass operation for the treatment of severe obesity, first described in 1997, formerly professor of general trauma, critical care, and bariatric surgery at the University of North Carolina in the United States. He's also associate chief of staff and first chief of the section of medical information in the Department of Surgery in the University of North Carolina, founder and director of North Carolina Trauma Registry. Welcome to you. We also have Dr. Sonia Ciappetta from Italy. She is head of Obesity and Metabolic Surgery Unit, Center of Excellence, Ospedale Evangelico Betania in Naples, Italy. Welcome. We also have Professor Karl Reinwald from Germany, head of the Department of Obesity and Metabolic and Plastic Surgery at St. Franziskus Hospital, Cologne, Germany. Specialist for Nutritional Medicine and Sports Medicine, President of 2019 International MGB-OAGB Club Congress, and President of the annual MGB-OAGB Consensus Conference in 2019. We also have Professor Safwan Taha from the United Arab Emirates. He is consultant, laparoscopic, bariatric, and metabolic surgeon, director of the Metabolic and Bariatric Surgery Center, and medical director, Mediclinic, Airport Road Hospital, Abu Dhabi, in the UAE. He is governor of the UAE chapter of the American College of Surgeons, governor at large, board of governors of the American College of Surgeons in Chicago. Welcome to you. And we also have Professor Caetano Marquezine from Brazil, former president of the Brazilian Society of Bariatric and Metabolic Surgery. And Dr. Umar Ghanem from the United States, attending minimally invasive surgery and bariatric surgeon at the Mayo Clinic in Rochester, United States. He is editorial board of SWORD, Leadership Roles and Sages, and America's Hernia Society. And Professor Matthias Fobi from the USA and India, Director of Clinical Affairs and Research at Mohawk Bariatrics and Robotics, Indore, India, Clinical Professor of Surgery in Sri Aurobindo Medical College and Postgraduate Institute, Indore, India, founding President of the Bariatric Corporation, Bariatech Corporation, and member and past chair of IFSO Board of Trustees, President of IFSO 2008, and President of the ASMBS Foundation 2006-2008. I will now pass it on to Professor Sandeep.
Hi everyone. Can you hear me?
Yes.
Thank you very much, Harris, for this kind invitation, and Dr. Musella for the introduction. I'm really honored to be a part of this esteemed panel and initiate the discussion on this topic which Harris has given me. Should surveillance endoscopy be routine after mini-gastric bypass to detect marginal ulcers? So, this was I think the paper we published very recently, obesity surgery, which was sort of the focal point of this discussion. in which we sort of, endoscoped 57 patients who were eligible for a year follow-up after OAGB, among whom about 3/4 consented for a surveillance endoscopy. 4 patients developed marginal ulcer, all less than 5 millimeter. All were asymptomatic and non-smokers. 3 of them healed completely on a repeat endoscopy on conservative management, and 1 patient was lost to follow-up. So the questions I'll be discussing with the panel are, is the problem of marginal ulcer significant enough to warrant surveillance? And should the surveillance be routine or selective? And then we'll take on from there, various from where the panel discussion goes on. If you look at the challenges of the marginal ulcer, there's a wide variation in reported incidence depending on length of follow-up. And it's a complex issue. And one of the most important issues is a conflicting literature on the etiology. I mean, that's the most, confusing aspect of the, marginal ulcer is the varying etiology which leads to marginal ulcer. And again, there's a wide variation of disease severity and impact is poorly understood. And last but not the least, there's a high rate of recurrence following treatment and surgical intervention. So this is some of the recent data giving, the incidence of marginal ulcer after OAGB, which is more or less comparable, maybe a little less than Roux and gastric bypass. Although, again, since a lot of patients are asymptomatic, the actual incidence may be higher than reported. Since most of the patients are just treated medically based on vague upper abdominal symptoms without any endoscopic evaluation. And this is again a paper of a large cohort of patients from New York State database, which showed that marginal ulcer rate. This is from the Roux bypass, incidence of 6.28% and about 10% requiring surgical intervention. And we all know the morbidity of marginal ulcer, untreated marginal ulcer, and how it can lead to a significant morbidity for the patient. And the supposed advantages of surveillance would include prevention of complications, which I just mentioned in the previous slide, identify and modify risk factors, treat these patients, hence decreasing the need for surgical intervention, and hence reduce morbidity. So let me stop here and ask Dr. Professor Phil Shah. So would you recommend routine surveillance endoscopy after OAGB? And if your answer is yes, then when and what intervals? Dr. Shah? Hello.
Sorry, I was on mute. With an incidence of 3%, that's fairly low to do routinely. On the other hand, for those people that have risk factors for marginal ulcer, people that have a history of smoking or on NSAIDs, perhaps alcohol, I think you can make the case for individuals who may be higher risk than others. But routine surveillance, you'd have to do a lot of scopes, on an annual basis, and it seems to me that would be a long run for a short slide. So I think the high risk patients, I probably would consider that.
Okay, so the answer is no to a routine surveillance endoscopy, and you should do it only in high risk groups. And we'll discuss this aspect later on. Dr. Rutledge, would you differ or would you have the same answer?
I would not do routine surveillance.
Okay. Dr. Sonia, am I pronouncing your name right? Sonia.
In my opinion, I agree with Phil Schauer that only the high-risk patients should undergo endoscopic surveillance. But I have to say, in these high-risk patients, I do not perform gastric bypass. So maybe it's better to perform sleeve gastrectomy to do not have the risk in the future.
Okay. Any of the panelists have a difference of opinion on this? We heard the three,
I really do have a different opinion because, I'm an endoscopist. I do surveillance endoscopy in all my patients here in Brazil. We do mostly gastric bypasses, but I can tell you guys that the numbers are much higher than you see in the literature because what you're doing is examining patients that are symptomatic. And if you put together the numbers of the asymptomatic patients, maybe you can get a bigger number. So I believe that, yes, we do it in Brazil. The problem is, and the real matter about the discussion is that in some countries, it's not so expensive to do it. It's not so difficult to do it. And like here where I work, it's not really a big deal doing it. But I know that like United States, the costs are really high and there are some difficulties to, to have the access of doing surveillance endoscopy. But I really do believe you have to.
So Dr. Marchesini, what time interval after the OAGB would you recommend?
Well, I wouldn't change what I do for my Roux-en-Y gastric bypass. Here in Brazil, we're not doing OAGBs, only small centers are doing it, but I wouldn't change it because I've been reading a lot of literature about OAGB. Maybe it's the bariatric surgery that's more studied in the last 5 years. You have a lot of literature around it. And I wouldn't change what I do here. I do in my patients for Roux-en-Y gastric bypass 6 months and 1 year after. And then for the second year, I do it again. And then after that, I don't do it anymore. And I really get on these patients semi-symptomatic ulcers. And mostly when we do have some complications that are bleeding and perforation, these patients do not complain previous symptoms. So this is another issue, that the complications come usually from patients that uses NSAIDs or smokers, and they don't have any complaints or don't value the symptom they have because of the habits they have, eating habits. So I think it is important to do surveillance endoscopy.
Well,
As I
understand,
you would do it more often in the first 2 years because chances of marginal ulcer are more. Dr. Phoebe,
Yes.
You do a lot of endoscopies in your center in India. What is your opinion about surveillance endoscopy? Dr. Phoebe, can you hear me?
Yeah, sorry.
Yeah. So
We do.
as I said,
We instituted a routine surveillance endoscopy from October 2018. And we have found out that the incidence of marginal ulcers is much higher than reported because we do not only do symptomatic patients, we do all comers. We can analyze our data right now because when we did all comers, we endoscope patients at 3 months, 6 months, 1 year, and then beyond, depending on the patients who were willing to have endoscopies. Based on that, the first 126 patients who had endoscopic surveillance showed that we had about a 16% incidence of marginal ulcers after one anastomosis gastric bypass and about a 7% after gastric bypass. But our surveillance is not for marginal ulcers. Your question is kind of skewed. We recommend routine surveillance because with one anastomosis gastric bypass, we are worried about marginal ulcers, GERD, and other things. Barrett esophagus with it. So that's why we do routine. But if we're just going to do it for marginal ulcers, maybe your yield is not going to be as much.
Okay. So Dr. Omar wants to make a comment, I think, here. Dr. Omar?
Yeah. I think in theory, with the fact that mini gastric bypass has a Billroth 2 morphology or anatomy, the chance or incidence of ulcers should be less in principle. That said, just to avoid the bile reflux to the esophagus, by design, the pouch was made longer, so higher chance of acids or parietal cells in that pouch. Also, to make it a low pressure system, the anastomosis is wider, 4.5 centimeters. So just the dysphysiology of that the mini gastric bypass creates while talking about ulcers here, because of the wider anastomosis, more jejunal mucosa, because of the longer pouch, more parietal cells. So that effect that we should have from the B2 anatomy goes off. I mean, we're seeing a chance of 16%, like Professor Phoebe mentioned, or 10% in, as you mentioned in your paper, which is comparable to the Roux-en-Y gastric bypass, which is again in literature is about 8 to 12%. So again, by design, it should be protective, but to avoid the bile reflux effect to the esophagus, it was made a longer pouch, wider anastomosis, more jejunal mucosa that is really getting exposed to the high acidity of the pouch. Not to forget 2 other things. We don't know what the effect of the vagal transection on the lesser curve side is doing to the remnant stomach hormones and as well as the bile acid production in the BP limb. Also, we don't know what the length of the biliopancreatic limb, what kind of effect it has, and what is the bile acids that are reaching that anastomosis, what is the concentration, and how much of a protective effect they lose with the longer BP limb that there is.
So as I understand, Dr. Omar, you are in favor of doing a surveillance endoscopy in view of the high reported incidence.
I would say yes, except that most doctors after mini gastric bypass put patients on PPIs. Dr. Mahawa reported in Clinical Obesity 2017, 85% of surgeons put patients on PPIs. So for those asymptomatic patients, what are you going to do differently? They already are on PPIs. You're not going to reverse them for asymptomatic ulcers. So that is the underside of it.
So that was my subsequent point. So would you do it after you stop PPIs? Let's say you give it for 3 months, so you do the surveillance at 6 months. Maybe we can ask Dr. Taha on it. Maybe Professor Taha can come on it.
Well, I'll come to that.
Surveillance endoscopy. Would you do it after you stop your, initial prophylactic?
Well, I'm sorry, but I'm very sorry to be the devil's advocate here, because I mean, all the things that we're talking about are, sound great. All the theory behind it sounded great. But if you're working somewhere where I work, where your load is 98% insurance, and you get, you get into fights literally to get approval for pre-op endoscopy for Roux-en-Y gastric bypass, or for a patient who is having dyspepsia, but he's not so obese after a previous operation. And now you are operating just to divert the bile, and the insurance sees no indication. I mean, it will be really, really, I tell you, 100% rejection if I ask for endoscopy for an asymptomatic patient following bariatric surgery. I guess the real question would be, I don't know about practices elsewhere. The real question for us working in mostly insurance-dominated practice is, for what you need is help from other centers who are referral centers, or they have certain grants or budgets to come up with data, because the easiest part for us here with insurance is when you show them the IFSO or the ASMBS guidelines, and then that's a different issue. So you can't really talk about it. I generally don't give my patients routinely PPIs, only those who are willing to pay for it, because insurance never approves it without symptoms. I mean, from the evident data, I would go for, if I had the means, I would go for a year, definitely.
Okay. So I think it's more or less the house is divided on that. And maybe we can take the next part, which Dr. Phil Shah raised about endoscopy in high-risk patients. So now let's see, what do you mean by high risk? And that's an area where a lot of, overlap is there, and a lot of confusing literature is there. And this is a recent paper from Rutledge, who's looked at the mechanism of risk factors of marginal ulcer. And we all know that diabetes mellitus, hypertension, obstructive sleep apnea, previous history of peptic ulcer disease, H. pylori, smoking, chronic use of NSAIDs, and various surgical aspects. Now, let me ask Dr. Carl Reinwald, what group of high risk, what do you consider as high risk? Is it a single factor or a combination of factors? If it's a combination, then what combination of factors?
Okay, thanks for this difficult question. I think we don't have real evidence on this. We don't have evidence what is a high-risk patient, but we all know these factors, and we should avoid on operating on high-risk patients, as you mentioned. So in my center, we don't do gastric bypass, and we don't do OHEB in smokers who deny stop smoking before surgery. Of course, a lot of them will restart surgery, and then we see about 50% of marginal ulcer complications are in smokers, but 50% are not as well. So that's one of the issues. But concerning your endoscopy in Germany, we got almost the same situation as in Egypt. We can't, and we have the problem of compliance of patients. They will never come having routine endoscopy like 3, 6 months, 1 year after surgery. But we do recommend now having surveillance gastroscopy like 2 years after surgery, but mainly, as Dr. Phoebe said, to also for the reflux issue, to have some security concerning silent esophagitis, silent bile reflux or so, as actually we do in sleeve gastrectomy. It's the same problem in sleeve gastrectomy.
So, okay. So you think you're suggesting you better not do a bypass in patient with high risk factors. Let's go back to Dr. Shah again. You mentioned you would be happy to do surveillance endoscopies in patient with high risks. And so let's hear your opinion on what you consider as high risk, where you would do a routine, surveillance endoscopy at some interval.
Yeah, well, I mean, I think the risk factors have been identified. We all know, smoking and NSAID use, H. pylori. Now, to the extent possible, some of those are modifiable, before surgery. So if they can stop those things beforehand, that's the best option. But as just mentioned, that some patients will restart some of these bad habits afterwards. So in that situation, you do the best you can to convince them to stop their bad habits. Stop smoking, stop the NSAID use, stop the alcohol. To the extent that you cannot, modify those risk factors, that's the group that probably should have endoscopy. But I must say, surveillance endoscopy is not practical. It's very challenging to follow these patients and schedule their surgery every year and have adherence to that. So it is an ideal goal, but it is not very practical.
Right, I would agree to that. And but let's talk about diabetes. In the recent paper from in the Annals of Surgery, they said diabetes is has a maximum risk along with the history of peptic ulcer disease. So would you agree with this viewpoint that you should scope the diabetics, maybe even if they're getting better after bariatric surgery? Again, I know your view. You already said that it's not practical, but would you agree with that paper if you've seen that
My
diabetes?
The question is, I think you're assuming, is diabetes not a modifiable risk factor? I say it is, because a lot of the operations that we do put these patients into long-term remission. Sure. So I take issue with this notion that patients with diabetes after metabolic surgery are still at risk for marginal ulcer, because in many cases, well, almost always, their diabetes is better, and a significant percentage of time we put them into remission.
Yes, but that's what the Annals paper said for more than 20,000 patients with a hazard ratio of around 2.5, if I'm remembering correctly. So let's go to Dr. Rutledge now. Dr. Rutledge, would you do surveillance endoscopy in high risk groups, maybe smokers or a combination of high risk factors, as we sort of mentioned in the earlier slides, Dr. Rutledge?
No, I think especially in India, there's a cost benefit, and the other points are that a lot of the risk factors are modified by the operation. If I could, I'll mention something else which I think has been left out, and that is the fact that the majority of the ulcers are found relatively early. And we've talked a lot about acid, and I think in general there is a significant decrease in the acid load placed on the mucosa of the Roux-Y and the MGB stomach pouches. My own experience in working with patients and surgeons and training them is we found that some surgeons seem to have an oddly high rate of marginal ulcers, and others seem to have quite a low rate. And there also seems to be a experience factor. And so one thing I haven't heard mentioned very often is the risk of ischemia. My feeling is that focus on the vascular supply to the gastrojejunostomy is an under-recognized problem for the development of marginal ulcer. Marginal ulcer certainly can occur late, particularly in smokers, as has been pointed out. But the early ulcers, I think, especially from the videos when I work with surgeons who are adopting MGB, or when I get patients or surgeons who've had a complication and we're able to look at the videos. My bias is that surgical technique often violates the principle of having a well-vascularized tissue on either side of an anastomosis when you do GI surgery.
Dr. Fobi, I think one of the previous speakers showed Dr. Kamal Mahavar's paper about extended prophylaxis of up to 5 years. And maybe most of the people of us would agree up to 2 years, 5 years is too long. So would you say it's better to do a surveillance endoscopy rather than putting the patient on extended PPIs? Dr. Fobi?
Yeah, this is a complicated issue because we don't have the data. At Mohawk, we're trying to generate the data. When I looked at the statistics at Mohawk, before I started routine endoscopies, we did not have too many patients coming in with complaints of marginal ulcers. And then when we started the routine endoscopies, only about 2% of the patients came in complaining on whom we found marginal ulcers. So the other 14.6% had no complaints, and that was an endoscopic finding. So we're talking here, and the reason is we don't have the data and people are being dogmatic. If you don't look, you don't find.
Right.
And if you look, you might find too much. So
Okay.
we have to have an open mind about this. So talk about
Maybe that's
surveillance.
why
We did
people don't look.
Well, when you don't look, you don't find, yes. But again, when people find, don't condemn them for finding or saying they're doing something wrong.
Yep.
Because as I said, I came and I can tell you, looking at the data, we had a very low rate of bile esophagitis complaining, low rate of marginal ulcers. But when we started doing the endoscopies, we found it was different. So there are many patients who have, so at this time, it should be a research topic for those who can do it to document it for the rest of us.
I think we look forward to your publication, which is showing this high rate of marginal
And
ulcers.
Dr. Fabi, I totally agree with you because we cannot pretend it doesn't exist because we don't do the exam. So this is a big issue. I think it is a problem. I understand some countries has problems in doing surveillance endoscopy, but we can't pretend the problem doesn't exist because we're not able to do the exams. This is something important you just raised on the conversation.
So, Dr. Marchesini, since you say routine surveillance endoscopy is desirable, would you be more strict about it in high-risk groups? And if yes, which groups? Let's say we all know smokers have a high risk. Let's talk about patients on non-steroidal anti-inflammatory drugs or diabetics. Are you more strict on doing an endoscopy in these patients? You're more regular.
What we do in our service here, we're doing bariatric surgery for 25 years, almost 30, 27 years. And what we do basically here is give the patient the most information we can do about the possible complications he will probably confront during his probable years. Because the thing is, and the problem we have is the follow-up. All of us has this problem. After 2 years, we lost a big number of patients. After 5 years, it's ridiculous what we are doing in terms of follow-up. So what we are doing now, and I think that what's helping the patients now is the internet and all the information we're putting out, is telling the patient, look, you may have this, this, and this. And if you have this and this symptom, please come to our service or go after an endoscopist or go after a service that's specialized in bariatric surgery. Do not go to a place that they don't understand the surgery because they won't know how to manage it. So this is one of the things that it's most important of everything. You tell the patient what are the problems he may encounter during his life and where he has to go to get some help. I think this is the most important thing.
Okay. So any other panelist has an opinion about the risk factors? Which factor do they consider the most important besides smoking? We all know that smoking is important. Let's say H. pylori. Dr. Sonia, do you think H. pylori is associated with increased marginal ulcer, and do you routinely eradicate this bacteria before surgery?
Yeah, I have to say I eradicate in all my patients prior to surgery Helicobacter in all patients. I recommend to avoid smoking. I recommend deeply to avoid NSAIDs. So I think these are the three most important things to do. The prevention, we have to focus on prevention because we can't do surveillance in all our patients. The high volume centers, the specialized endoscopists can do it to have data, to publish data. But I have to say, in the normal life, we have to go.
Okay. So, Dr. Reinwald, if supposing patient has to have an NSAIDs, would you do a surveillance endoscopy? Because they're likely to have, supposing they have to have those drugs. Dr. Reinwald?
Thanks for this question. Actually, we recommend taking these drugs only for the shortest period possible. So say 2 or 3 weeks under coverage, under protection with PPI at that time. But we strongly recommend not taking these drugs like ibuprofen or diclofenac or so on a long run. We strictly forbid aspirin. Of course, that's the worst of all the drugs, as we know. But we would not operate on a patient, on a rheumatic patient, for instance, who needs NSAI on a long run. So in these cases, we would go for sleeve gastrectomy.
Okay. So I'll just show you some data on the risk factors. I mean, this is again from large population cohort studies, more than 30,000 cases. And among the risk factors, the treatment for diabetes at 1 year and surgical factors like a large pouch and a prolonged operative time was found to be important. And they also found that PPI prophylaxis did not increase risk of marginal ulcers. Is it going down? It's not moving. Can you hear me? Regarding the aspirin, I think my slides are not moving. Can you see my screen, please?
Yeah, we can. You may have to unshare and share again.
Okay.
Not moving.
I can see it. It was
okay. Right. Okay. No, I think it's not moving. I'll stop share. So again, the data about aspirin is very interesting. I mean, the low dose aspirin is found to be actually beneficial in some of the studies, and only the high dose aspirin has been found to be a problem for marginal ulcers. Now let's compare what prophylaxis, PPI prophylaxis. Do you think, Dr. Omar, that it helps in preventing marginal ulcers? And then, yes, how long? Because there are some studies which say they don't, like one I was about to show you. But how long do you give PPI prophylaxis? And
I raised my hand just to comment on the modifiable risk factors. We talked about the patient's modifiable risk factors. We didn't talk about the technical modified risk factors by the surgeon. And Dr. Rutledge kind of commented on that. I felt there is some kind of a blame for the surgeons who do that, but it's sometimes there is just the techniques we use. I feel from our experience at Mayo Clinic doing hands-on anastomosis, I do a full hands-on anastomosis myself. From our experience before, using a permanent suture caused more ulcers and more stenosis, in fact, and that's why we changed to Vicryl. Now, recently, even Vicryl, it might have some inflammatory effect, and we are, some of the surgeons who do hands-on anastomosis, including Higgins group, just changed recently to using PDS for that reason, just because it is less inflammatory and might be associated with less ulcers. I haven't seen as much ulcers with Vicryl being an absorbable suture, but again, that is an interesting point also to check what are the modifiable risk factors that the surgeon can introduce with the technique. Now, the staple that is used, surely that's permanent material. If any one of us, and I'm sure all we did, we scoped early after an operation done by stapled anastomosis. You see those staples coming out into the intraluminal area. I do not think this is something to be neglected. This is important. So modifiable risks or risk factors by the surgeon's technique themselves is important. Going back to your question, we do give PPIs for a period of 3 months after our Roux-en-Y gastric bypass patients. There is a good study that you already highlighted on, and I believe it's a meta-analysis. Now, It's a meta-analysis of some bad studies, unfortunately, but that's what is available in literature, and we do give 3 months of PPI prophylaxis afterwards for that matter.
Dr. Taha, do you have any difference of
Thanks a
opinion?
lot. Actually, I have a question to Dr. Sonia. I mean, she said that she eradicates H. pylori from every single patient that she operates upon. So what's the approach? I mean, you scope them all, take tissue biopsy, and then give medication and scope them again, or it's a breath test, or what are the criteria through which you eradicate every single patient from H. pylori? I'd love to know that, really.
So every patient who has a positive pylori. So every patient in my center gets a preoperative upper endoscopy with a biopsy. When biopsy is positive for Helicobacter pylori, I recommend Pilera for 10 days, and they repeat breath test.
Even if they are asymptomatic?
Yes.
But, you know, roughly 66% of people who have nothing will have a positive H. pylori test. So wouldn't that be a bit overdoing it? I don't know. I'm just asking.
I don't know. I have to say, I have worked for 10 years with Rudolf Weiner, and we did upper endoscopy 1 day before surgery. And now I am doing upper endoscopy when 2 months, 6 weeks prior to surgery, because I have so many patients and have to organize. And with this flow chart, I'm going well. I do not have seen so many ulcers, so I go on with it. Maybe I'm over treating, but
I would have done that. I would have done the same thing had my insurance covered it. But I think if you do have the coverage, of course, I think through experiences like yourself and other people who do, like Professor Phoebe, who do a routine endoscopies, probably in a couple of years or 3 years, we can come up with data that can support us people who work under insurance. Thank you.
So there's a question from I think one of the surgeons, that should we offer a bypass to patient on chronic NSAIDs or drug modulators like for rheumatoid arthritis? What is the opinion of the panel on that? Anybody wants to take an answer on that?
I think yes, you can. At one point in the United States, the only surgery we had was a gastric bypass. And so we operated on all patients, those who were on arthritic medicines, those who were on steroids. And when we looked at the data, it was not that significant. That some patients.
So Dr. Phoebe, I was just showing this slide.
Had more ulcers.
So I was just showing this slide. Can I share this slide for a while you speak? So this is a paper again from a very large database showing a current chronic NSAID use as the most significant factor. I remember the odds ratio was more than 10. And among all the factors in such a large cohort, so I would agree with this would be my opinion, and other panelists can comment that maybe we should not be offering a bypass procedure. Dr. Phil Shah on this?
Yeah, we know a lot of these folks with the weight loss, their arthritis gets better. So many of the patients, you can get them off their NSAIDs. So that's an important point. But the ones that do need long-term NSAIDs or anti-inflammatory drugs, I would put them on extended PPI prophylaxis, and perhaps in addition, a cytoprotective agent like Carafate, in addition. So I would prophylact those folks, and that's the group. If you're going to offer surveillance, that's the group where you should survey the patients.
Okay,
yeah.
so any panelists who would refuse a bypass to such patients? Anyone who would say, okay, well, I won't do a bypass?
I actually would. I do this that Phil just told. We have a number of patients that do use NSAIDs chronically, and we do use PPIs chronically too, as the same. So it is important. We know it is a risk factor.
So it seems that we can offer a bypass with cover of an extended PPI/sucralfate. Is that right?
Yes, I do agree. I think there's no problem for OAGP or for you have to put on the table the benefits of the surgery here, not
Right.
only the maleficence of the surgery. And the benefits of the surgery, Phil just said, these patients will get much better from their arthritis and their problems of using NSAID. So they will diminish the use of it. So I think there's no problem in taking care of these patients with more, looking there more closely and taking care of them and telling them the risks of using these drugs.
Right. Dr. Phoebe, you were saying something?
Yes, you were quoting the paper. I've looked up this topic. Do we have anybody that has published on patients who presented with symptomatic marginal ulcers after gastric bypass and show the correlation between taking NSAIDs and the incidence of ulcers? I couldn't find that reference.
I think I just showed this paper, which is looking at
I remember that
marginal
one.
ulcers only. 35,000 patients, or let's say with marginal ulceration, who have undergone bariatric surgery. So this is a pretty large cohort of marginal ulcer patients, not only the bariatric surgery patients. So I mean, we need to have a closer look at the paper, and probably this is the only paper which has shown this.
Yeah.
So maybe we need to have a look at the other papers. I'll just throw up an idea. If this is my
can I just address this other thing about H pylori?
Yeah.
When I looked at the incidence of H pylori, when I came to India, I came from the United States where we did H pylori tests routinely and eradicated positive tests with antibiotic and other medications before surgery. When I arrived at Mohawk, they had done about 7,000 cases and they were not doing H pylori tests. I kind of got irritated. I got very rambunctious. And then I looked at that data and I didn't see that they had any particular problem with marginal ulcers. Maybe we're treating something we think would be happening, which we don't really need to. I just thought I'd bring that point up.
Right. Okay. So again, as this paper from Dr. Mahawar showed, that there's no conclusive evidence to prove that eradication of H. pylori reduces marginal ulcer rates. And I've seen a lot of literature which is on both sides. So this is again an equivocal sort of a risk factor. Again, I think I'll just throw up, this idea of this paper from Sweden. This showed that, patients who have perforation have certain high risk factors like young age, but totally different from the other risk factors we have seen. Young age, white race, and profound weight loss. Do you think these factors, although they're from one paper only, could be used as a guide to surveillance endoscopy? And because these are the risk factors for a perforation or a complication of a marginal ulcer. Would any of the panelists want to take a guess on this or opinion on this? Have anybody, do you agree with this? This is from data.
I would have to say, Sandeep, I'd like to see other papers validate that, because if you're talking about young patients, so what do you mean by that? What's young?
I don't like Dr. Phoebe, my age.
In white, that's a high percentage of patients in the Western Hemisphere anyway. So I think it needs to be validated, yeah. But if I can, I want to go back to Mal. Mal, did I hear you correctly that you said there was 16% of patients with OAGB have a marginal ulcer on surveillance, and it was 7%
yes.
for Roux-en-Y. Is that correct? Because that's the highest I've seen.
So
I guess,
maybe
yes.
I guess it really begs the question, though, is...
But we did this on every patient.
Okay. It's the first time I've seen that the OAGB has twice... The OAGB has twice the marginal ulcer rate that a Roux-en-Y. So that's new to me. But it also begs the question, how important, is an asymptomatic ulcer? And in my own experience, not all, but most that end up with a catastrophic problem like a bleed or perforation, if you talk to them carefully, they're usually symptomatic, in my experience, before they have the disaster. So I think that's worth the discussion.
Can I say something on this? I think, again, one of the papers showed 1 in 5 perforated marginal ulcer. The perforation was the first presentation. So maybe, as you say, you take a detailed history, you may find some symptoms, but again, some of them are very vague. And so marginal ulcer, asymptomatic marginal ulcer is a problem, whether they need to be treated and, whether they go on to perforation, we need to have more data. I think maybe when we're inching towards the end of the discussion, let's have one final comment from each of the panelists. Maybe we can start in the reverse. Dr. Oma, can you want to make a final comment? And I'll just make it.
Yeah, I believe with all the studies that were presented today, including the study from your group itself and the data that Dr. Phoebe just mentioned, I think we need more publications to validate every single risk factor that is causing these ulcers and to check further on the modifiable risk factors, again, from the patients and the technique itself. And these are procedure specific sometimes. The importance of the paper that you mentioned or that you published is that it shows also that mini gastric bypass, as any other surgery we do, has complications, and this is a fact, and we just need to be more cognizant about it, and we need to report it to see how we can get this problem or this pathology better.
Right. Dr. Taha?
Thanks a lot. Thoughts on this? Yeah, one last thing. Omar mentioned something about the effect of the vagus nerve when transected, about the evacuation of the retained stomach. Actually, Professor Muhyi Benna of Egypt published a paper, I think, a few weeks back about vagus nerve preserving, OAGB, and we've been doing actually some of those cases, but didn't publish it yet. We yet to find the actual effect of that, but I think that's probably one way of eliminating one risk factor also.
Dr. Reinbold, we have final thoughts, let's say on surveillance endoscopy versus extended TPIs, or anything you want to say?
Yeah, yes, thanks. Actually, I got the message that I feel that we have to adapt our algorithms to our patient populations and to our infrastructures, and so it might be very different operating on patients in India, on United States. The compliance is different, the BMI is different. There are genetical factors, and all this we must consider our personal local experience. Of course, that's my feeling, and in general, I feel it's not a bad idea to have some kind of endoscopic follow-up, to try to have it at some time. If it's after 1 year or 2 years, perhaps it's not so important, but I feel we should try to motivate our patients having some endoscopic control, at least during the first 5 years after this kind of operations. And also I feel reconfirmed with a kind of post-operative prophylactic PPI intake, whether it is 3 or 6 months or so, but perhaps not more. That's my my opinion. Thank you very much.
Thank you, Dr. Sonia. Your thoughts, final thoughts?
Yeah, conclusion.
Takeaway for the audience? Yeah.
4 things. Prevention, talk to the patient about the lung complication risks. So communication, and choose the right procedure, the right bariatric procedure for every patient based on the risk and comorbidities. And the 4th thing I have to say, endoscopic surveillance, I have to indicate only in high volume centers for studies, publications, to have data, not routine.
That's very well said. Dr. Rutledge, you're the originator of this operations.
Just 2 comments. Number 1, I think that reviewing the recent data on H. pylori eradication in countries where the risk is high of gastric cancer related to H. pylori has been somewhat disappointing because of the induction of resistance. So I think it's worth looking at that topic for the MGB purposes as well. And then otherwise, I would compliment the group on the discussion.
Right. And Dr. Phil Shah, and then last but not the least, Dr. Phoebe.
Yeah, no, I just want to thank the IBC for putting on, this program. I do think, marginal ulcer, whether it's, from a one anastomosis bypass or Roux-en-Y, in my opinion, is the Achilles heel of this procedure. And, since surgeons began, or since Dr. Mason, the late Dr. Mason, began performing, gastric bypass as a loop bypass, over 50 years ago in 1969, this has still been a problem. Perhaps we've reduced the rate slightly, but still it's a problem. So I think it behooves all of us to keep this in mind as we prepare patients for surgery, to modify their risk factors, perform the operations with good technique, paying attention to all the technique, to minimize the ischemia, using absorbable sutures, and then finally, paying attention to good post-operative care, prophylaxis where it needs to be done, surveillance where it needs to be done, to try to reduce this problem that has been ever present for 50 years. It's the Achilles heel of these procedures.
Thanks for the comments. And finally, Dr. Phoebe. And maybe Dr. Ken Lowy wants to make a quick comment after Dr. Phoebe.
Go ahead, Ken.
Dr. Phoebe.
All right. No, I think Phil has wrapped it up completely and effectively. The truth is, marginal ulcers will occur after any bypass, one anastomosis, long limb, just for the nature of the operation and the fact that we're connecting the small bowel to the stomach. The question is, how significant is it? As I was talking to what study we're doing in terms of surveillance, even though the percentage was high in the OAGB group, but when we looked at those who presented with symptoms, they were both around 2.3 and one was 2.6%. So there's difference between what you find doing a routine test and what the patients come complaining with. So the point is that these things do occur, they are significant, and we have to do whatever we can to minimize their occurrence. Thank you.
Yeah, thank you, Dr. Phoebe. Ken, you want to make a quick comment before I, summarize the panelists' opinion? And
in Australia, I think we had the privilege of treating multicultural patients, and I think we had a cohort of Middle East patients, we had a cohort of white Caucasian patients. We don't have the mandatory to screen everyone, but there's a lot of excuse to screen anyway. If they have iron deficiency, if they have history of abdominal pain, if they are Helicobacter, we do screening for colorectal cancer, right? Obviously, all those are excuses to stick a camera up the throat and have a look to identify the problem. So it shouldn't be an issue, but we don't mandate it. But there's disproportionately high marginal ulcer rate in our Middle East cohort. And I think a lot of the time we ask them is they say they don't smoke, they usually don't drink, but they do occasional shisha, which apparently is a very high concentration of nicotine, which probably can be a problem. So I'm wondering whether if any of the panel have seen this sort of issues.
Anybody who wants to respond to Ken?
I just come from a country that smokes a lot of shisha, and yes, it is more concentration for sure. And if you ask anyone who smokes shisha, which they do about 6 or 7 packs per day, they would tell you they don't smoke. They don't consider smoking, unfortunately. So this in a country that has a lot of Middle Easterns, I guess, coming from Middle Eastern countries or the MENA region, I believe that's something that should be screened for as well.
Well, thank you very much. I'll just wrap up. I think, so I think most of the panelists agree that it's a significant problem. And the House is obviously divided on the protocol for surveillance endoscopy with roughly 50% on each side. And Dr. Rain was saying the logistics also dictate how we go about following these patients. Obviously, logistics, the policy of the center in the insurance cover. The communication is very important, as Dr. Sonia said, about patient being counseled about that it is a problem which can occur, especially in the first 2 years, and they need to take some sort of prophylaxis. The duration of prophylaxis varies, but most of us agree from a 3 month to 2 years, and maybe 5 years if the data is available. And I think the other risk factors like H. pylori and smoking and NSAID use have been discussed, and they're important to be modified. I think for surveillance endoscopy, I think we're keenly awaiting Dr. Phoebe's paper and maybe more data. And so I think we definitely need more data before we can recommend a surveillance endoscopy. But high-risk group surveillance is a doable thing. And maybe there's a midway between a routine surveillance for all patients versus surveillance for high-risk patients. I thank all the panelists for their valuable time and comments, and which made really this discussion very enriching. And I hope all of us benefited from this discussion. Thank you, Harris. Thank you, everyone. And bye. Thank you.
Thank you, Professor Sandeep. This was spectacular. And before I pass it on to Professor Mario Musella so he can give us some closing remarks, I want to say we have around 5,000 plus live viewers for this event. It was a spectacular event, and I have to tell you, Sandeep, you kept our panel of experts on their tiptoes today. So I'll pass it on to Mario Musella for some closing remarks.
Thank you very much, Ariel. Well, I've heard a very interesting presentation and a lot of interesting and authoritative comments, of course. Well, I would like to stress just what Sonia was about to comment with regards to the endoscopic surveillance of the OHB or in general of any bariatric procedure. I believe that one issue is a study setting. I mean, a research institute in which we scope all our patients to detect any eventual ulcer. And according to the paper that Dr. Agarwal showed us at the beginning of this presentation, in my opinion, currently it is not justified to make a regular surveillance for the one anastomosis gastric bypass. At the moment, the results we have, they do not justify. So one issue is the research and other is the clinical practice. Of course, I agree with Dr. Schauer when he says that it's not justified, but I believe not only for the one anastomosis gastric bypass, for the simple reason that it is not only a cost-benefit reason, but even because if I should ask to my patient that is in good health and is in good shape, is having good results with any bariatric procedure to undergo an GDS, he probably would escape. So I think we should take in account this with regards to our patient in the clinical practice. So one issue is the study and other is the clinical practice. So this is my very humble opinion.
This has been an IBC Oxford University Hot Topics in Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. Register to obtain CME credits for this and upcoming events at cine-med.com/IBC 2021. To view past Hot Topics in Surgery episodes, go to ibcclub.org or any of our social media platforms. Don't forget to mark your calendars as the 3rd IBC Oxford University Congress has been rescheduled to September 19th through the 21st of 2022. For more information, go to ibccongress.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
My name is Gary Teagan. I'm the Senior Director for Clinical Affairs at ConMed's Advanced Surgical Division. So ConMed Corporation has been dedicated to smoke evacuation for some time. First with its own line of smoke evacuation products for open surgery and laparoscopic surgery. Second, with the acquisition of SurgiQuest, which brought to market really best-in-class laparoscopic options for insufflation and smoke evacuation with the AirSeal system. ConMed purchased a company called Buffalo Filter, which was regarded as the leader in smoke management. The AirSeal IFS, or Intelligent Flow System, works with 3 different modes of operation. The first mode is AirSeal mode, and that basically provides a constant pneumoperitoneum and continuous smoke evacuation. It also incorporates the use of the AirSeal access port, which is a valveless trocar. There's a group of super users, which we've given instructions to, that enables them to use it in such a way that it minimizes the potential for gas venting out the top of the port. Any gas that does go back to the IFS is filtered down to 0.01 microns using our proprietary filter, and that was validated independently by an outside organization. The IFS also has a second mode called smoke evacuation mode, and this is our closed loop solution. By closed loop, I mean there's an insufflation line and a smoke evacuation line. It can be used with two conventional trocars, standard trocars, as long as they have lure lock connectors or stopcocks. And this basically provides a continuous loop of insufflation and smoke evacuation. When the gas returns to the IFS, it is filtered through the same filter media, which filters down to 0.01 microns. The third mode that the IFS has is something called standard insufflation mode. And this basically functions like any other conventional insufflator. It provides carbon dioxide and then senses every few seconds to make sure that the pressure is appropriate. But we often recommend the use, certainly in the COVID area, of an ancillary smoke evacuation system, something like the Plume Port Active, which is made by Buffalo Filter, recently acquired by ConMed Corporation. And this product connects to the canister on the ground and also contains a 0.1 micron filter.
So Gary, tell us about what the whole system is comprised of.
So you basically need the IFS and then your choice of 3 different tube sets. Again, the ASM evac for air seal mode, this SEM evac for smoke evacuation mode, and what we call the SIM tub, or standard insufflation tubing. People buy the air seal system to use it in air seal mode. The COVID area has actually opened up another opportunity for us with our second mode, which is smoke evacuation mode. And that incorporates a tube set that has 2 lines that split. One goes to, they both go to the stopcocks of individual trocars, conventional trocars. And one is an insufflation line, and the other is a smoke evacuation line.
Can I understand then that also the micro droplets produced by the ultrasonic devices, will those also be removed?
That's a great question. So in both air seal mode and smoke evacuation mode, the air seal IFS is drawing gas from the cavity back to the box for filtration. And that basically, it filters any gas that comes back, whether it be smoke from electric cautery or some type of plume from an ultrasonic device. Can be drawn back to the IFS for filtration, and then either departure out the back of the box in smoke evacuation mode, or recirculation back to the air seal access port if you're using it in air seal mode.
How does one find the devices or contact the company for more information?
So ConMed is an international organization. We have primarily direct representation in most countries. We have distributor representation in some countries. You can certainly email me at garytegan@conmed.com, and I will forward the contact information for the person requesting information on our products.
So this is Spotlight on Industry, Smoke Evacuation and Insufflation. We want to thank Gary Tegan from ConMed Corporation for joining us today.
Thank you for having me.